Hi, Dr. Schaffer.
Hi, Darryl.
Good. I'm very grateful for you to be here at our conference. And can you just tell us what kind of doctor you are and where you practice and what kind of patients you see?
Sure. So I'm a medical oncologist. I work at Vanderbilt University Medical Center in the Ingram Cancer Center. And I see patients in my clinic primarily with advanced prostate cancer, but I'm also happy to see patients with any diagnosis of prostate cancer, just to talk about their care.
So these advanced prostate cancer patients, and about how many a week do you actually see,
So it depends on the week, but I can see anywhere from 2 to 5 new patients per week.
Which sounds like a small number, but it's actually a pretty substantial caseload. Especially around advanced prostate cancer, it's not just the time you spent with the patient, it's all the before and after and investigation kind of stuff, right?
Exactly.
Yeah. So most guys with advanced prostate cancer, they're looking at androgen deprivation therapies and the new molecules that sort of take off from that space. But there's also another world, another kind of opportunity called immunotherapy that patients sort of know about, but don't really know about. So why don't we just sort of level the playing field for people and just what is immunotherapy specific to prostate cancer?
So in general, the term immunotherapy refers to a class of treatments that uses a person's own immune system to help kill cancer cells. And when a lot of people think about the immune system, they think about fighting bacteria or viruses, but there's also a role for the immune system to treat cancer as well. And sometimes when a cancer exists in the body, it's because the tumor is actually evading the immune system, or there might be cancer cells that are being driven in part or protected by part of the immune system. And so the term immunotherapy is evolving in prostate cancer to really help the immune system identify cancer as bad and try to kill those cancer cells.
But when we think about cancer cells, there's like a substantial sort of idea around them, like they're things. They're part of our body. They're sort of unwelcome creatures, perhaps, or, good cells that have turned into bad cells. But there's somehow at least in my mind, and I think in the people that I've spoken with over the couple of decades, that they're not viruses, they're not bacteria, they're things like a fingernail or a piece of skin. How is it that the immune system, which I think we sort of think of as helping us around like viruses and bacteria and stuff, how does that sort of figure out that something substantial like a cancer cell is also something that we want to get rid of?
So you are correct in that tumor cells are actual tiny little microscopic cells. And they can exist as individual cells or tumors. And the way that the tumor and the immune system interact is that within a tumor, there's actually something called a microenvironment. So it's not just a big mass of cancer cells, it's a mass of cancer cells intermixed with some soft tissue and also the immune system. And so the way that immune system cells interact with the cancer is that sometimes, if it's doing a good job, immune cells can kill cancer cells. If it's fostering cancer growth, they can actually protect cancer cells from being recognized by immune cells and protect them from being killed.
So it's a good or bad situation. It's not like the immune system is really always on our side, so to speak.
Exactly. And so the intention of immunotherapies as a class is to help harness the good immune cells in recognizing the cancer and allow them to do their job of eliminating cancer cells.
By the way, is it that there are good immune cells and bad immune cells, or is it that the immune system is really good, but we're training it to identify the bad stuff?
So all the immune system evolved over time through human evolution as for a purpose. And so in the context of cancer, there are individual cells that are helpful to the cancer and harmful to the person. because they are allowing cancer to exist. But those cells have some other purpose in evolution in helping the human. So in general, all immune cells are good. It's just in the context of cancer, sometimes if particular types of immune cells are present, we know it can suppress the ability of our own immune system to fight the cancer.
So presumably, if we look 5 to 10,000 years in the future, the immune system probably would have figured out by then what cancer looks like, what to do, and the good cells will go after them, and the bad aspects of immunity will sit aside. But we're not 5 or 10,000 years in the future yet. We're just here now. So what are the different kinds of immunotherapies that we could use today to sort of fight our prostate cancer?
So currently, there are 2 FDA-approved therapies for prostate cancer. One of them is sipuleucel T, also called Provenge, and another one is Keytruda, also called pembrolizumab. And when you think about when to use these therapies, it's really important to recognize that both of these are FDA approved, but for a particular type of patient. And it's important to look at what patients were in the trial and who really gets benefit from these therapies.
So they're 2 entirely different kind of things?
Yes, absolutely. So the mechanism by which the drug works is different, and the administration is also different too.
So go on.
So Provenge, or sipuleucel T, was the first FDA-approved therapy. It was in 2010. And this is a therapy that's actually composed of the patient's own immune cells. And so they take the patient's immune cells out of the body through a process called leukapheresis, and they prime the immune cells to be presenting or primed to a unique protein on the surface of prostate cancer called PAP. And so they take the cells out, they put them in a little petri dish and stimulate them, and then they put them back in the patient's body. So it's really their own immune cells that are primed to a protein that is pretty specific to prostate cancer. And then once that is back in the body, the intention of that is to stimulate other immune cells in the patient's body against the PAP protein in prostate cancer overall. The second therapy, which is Keytruda, is an immunotherapy. It's a checkpoint inhibitor. And so this works by given IV. It's every 3 weeks. And when the tumor environment exists, sometimes there can be a break on the immune system. So this therapy works by taking the brakes off the immune system and allowing the own natural immune system to recognize the cancer. So this drug was and is being looked at in a very broad population for prostate cancer, but is currently only FDA approved for when patients have unique genetic features. So patients that would qualify this have had genetic testing of their cancer, and they either have mismatch repair, high tumor mutational burden, or microsatellite instability. And those are technical terms, but they are basically features in your cancer that indicate you have a higher chance of responding to Keytruda or pembrolizumab.
So, and we'll use like the commercial names because even I don't know how to pronounce them correctly almost all the time. So Provenge might possibly be useful for pretty much everybody with advanced stage prostate cancer. And Keytruda is specific to a percentage of guys that meet a certain genetic profile that makes it a useful therapy. And what percentage, more or less, of patients would fit that?
So, and just to clarify a few points there, Provenge is appropriate and FDA approved for anybody with castration-resistant prostate cancer, meaning they've progressed despite castrate levels of testosterone. However, when you look at that trial had patients with very good function. So they were up and about, moving around. They did not have symptoms from their prostate cancer. And their PSAs, the people that got the most benefit had low PSAs. So in clinic, when we talk about who's really going to get benefit from Provenge, it's patients typically before chemotherapy, typically with not a lot of disease burden and no symptoms and very good function. So that trial showed about a 3 to 4 month survival benefit for people that got Provenge. So it does have a significant impact, but when you look at that total time, it's important to think about who exactly should get it. And it's really those patients asymptomatic and also low disease burden. The Keytruda and pembrolizumab, that population is a very small proportion of patients that actually have that germline mutation or somatic mutation. And the tumor testing is called somatic, and germline means you're looking for an inherited mutation. But if a patient has a genetic feature, then they can qualify for it. But this is only about 3 to 6% of patients.
So that's not very many, but it's on scale, that's thousands of patients. And do they also only get, like, on average 4 months of extra life, or how does that play?
So in terms of the benefit for patients, the really exciting thing about immunotherapy is that if patients do respond, they can have really prolonged responses. So there are documented cases, and I've been fortunate to help care for a patient who can have over 2 years of response with undetectable PSA, but this is extremely rare. Most patients on average in the trials look at about 6 to 8 months of response, and there are definitely patients that do not respond as well. So, but the exciting thing about immunotherapy is that for some select patients, you can have prolonged response. And so that's why, even though you have low rates of the mutations in the tumor testing, 3 to 6%, if you are one of those patients, it's a big opportunity to try.
Can those 3 to 6% do both?
Yes. So typically when patients are getting tested, if they have a mutation in their tumor, they may opt to try the pembrolizumab, Keytruda, rather than the Provenge.
No, but I mean, can they do both at the same time?
I don't know that would be common practice.
Right, but which is another way of saying maybe the doctor would do it and maybe they won't, you know?
Yeah. I think if you had Provenge on your planned list of therapies, I think they haven't been studied together. So I guess theoretically there could be side effects that would arise. And so most people are using drugs as indicated, as based on studies that have been done. And so, but yes, officially someone would be eligible to do both in sequential order.
Okay, let's talk about the side effects, and then we'll start talking about the really cool stuff. So what are the side effects of Provenge? What are the side effects of Keytruda, and, how many people usually experience those, more or less? So
typically Provenge is pretty well tolerated. Patients sometimes have muscle aches, some fatigue, headaches. It's usually pretty mild, though, some fevers and chills. The goal with immunotherapy and Keytruda is attempting to boost your immune system against the cancer. When there are serious side effects that come up, it's because your immune system is boosted against healthy tissue. So with pembrolizumab, autoimmune conditions can develop. And what's problematic with these is if they are causing inflammation of important or vital organs, that can be life-threatening. So if you get inflammation of your lungs or your bowels or your liver, these are hepatitis, colitis, or pneumonitis. These can be life-threatening and require hospitalization. And so it's really the minority of patients that have severe autoimmune conditions develop, but if they do, they need to be treated quickly. So for patients that are on immunotherapy, if you have any new symptoms, the rule of thumb is to call your team and get them managed earlier than later.
And can immunocompromised guys like HIV guys and such, can they use any of these?
So I believe that the trials did not include HIV positive patients, but they can be given to patients with HIV. As typically, it's recommended that their viral load is well controlled and their CD4 counts are normal. One population, though, that is not able to safely receive immunotherapy like Keytruda is patients that have known autoimmune conditions that are getting immunosuppressive treatments. And the reason for this is using these immunotherapies in this population can cause severe exacerbations of things like lupus or colitis, and that can be life-threatening. So essentially, patients that are known to have autoimmune conditions, it's a long conversation about risk and benefit.
So, let's just stick with the side effect just a wee bit longer. The idea of checkpoint inhibitors. I mean, we live in a time of COVID, and whether you read the Washington Post or the Washington Star or some left or right or whatever is your particular news source, most of us know about cytokine hurricanes and storms. The idea is that, we're going to drown in our own goodness. Our immune system goes haywire and our lungs get coated in such a way that we can't breathe anymore. And that's how many COVID people die in hospital, respirator or not. And that's the whole point of the respirator, to give people, give lungs a chance to get the valuable oxygen that they need. So a checkpoint inhibitor sounds like it's inciting one of those storms in our lungs. What keeps it from killing us?
So it's the majority of people do not experience inflammation in the lungs, pneumonitis. If they do, we immediately start things like steroids or immunosuppressive regimens. So every time we're seeing patients who are on immunotherapy, we're asking a long list of symptoms, and we do start treatment early. So it's a little bit hard to predict who is going to develop the autoimmune conditions. And, especially when COVID did start, there was concern, would immunotherapy be showing worse outcomes in patients because of the inflammatory nature of the drug? And so far, that has not panned out, that we are tailoring our use of immunotherapy. We are continuing to use it in cancer patients and seeing good outcomes. Okay.
So we've got two possible immunotherapy plays for patients. It's to be determined which or both, if you could sort of negotiate well and want to try it out with your doctor. And there are trials that were specific to certain kinds of patients, and the trials are what we base what you base the decision making, shared or not, but you base it on, who's appropriate for a particular drug and who's not, right?
Correct.
Okay. So now the obvious thing is, if this stuff works, why not, and it's, if, we're giving it to patients who are sort of dealing with, a late stage of their disease, why not just give it to healthy people to prevent prostate cancer?
So at some point, I do hope that we have a vaccine type therapy to prevent cancer. But if we were to expose a huge number of patients to drugs like pembrolizumab, a lot of those patients who may never develop prostate cancer could have the side effects from that therapy. And we don't have data yet to support that immunotherapy with checkpoint inhibitors prevents cancer. There are some studies being done, based in basic research and maybe in early human as well, looking at vaccines to try to prevent prostate cancer. But the data that we have thus far we don't have any use for that yet in terms of bringing Provenge or Keytruda into the preventative site. But it's definitely of interest. I think the trick with creating a therapy to prevent prostate cancer is you need to make something that does not attack healthy tissue, like the normal healthy prostate. And also you need to recognize that prostate cancer as an entity is highly variable from patient to patient. So when you look at the prostate cancer genetics of one patient compared to another, they can be completely different. And the proteins expressed can vary patient by patient. So we don't yet know one vaccine that would be effective to treat all prostate cancers.
Okay. And is it fair to call these vaccines?
So Provenge is considered to be a vaccine type therapy. Keytruda is not a vaccine. The term vaccine is designated more the checkpoint immunotherapy class is a different class than a vaccine. There are other vaccines in development also for prostate cancer.
That was the FDA saying, be careful, because Darryl's about to ask why Provenge and Keytruda aren't offered to earlier stage prostate cancer patients.
So the data that we have so far only supports the use of it in the metastatic castrate-resistant setting. For numerous trials that are ongoing, there is looking at bringing in immunotherapy into earlier and earlier stages for prostate cancer. So I won't be surprised in the coming years if there is something for localized disease or following management of localized disease. We're just not quite there yet.
So one of the deals with the virtual conferences, I have to imagine what 1,000 people sitting behind me are clamoring to know. And they're, I could sort of feel creepy fingers on my shoulders asking, well, why can't I negotiate with my doctor? I mean, is there anything really stopping my doctor from setting me up with Provenge and or Keytruda as early as me getting a positive biopsy?
So the payment for drugs is a big factor. So a lot of times insurance won't cover a certain therapy when it's not FDA approved. If you have interest in getting immunotherapy early in your prostate cancer treatment, then I would definitely encourage you to talk with your teams about if there might be a clinical trial that you would be eligible for. And there are a lot going on now, both in the US and internationally, looking at how to incorporate and see if immunotherapy can benefit patients. So talking about the risks and the benefits for those therapies and trying to figure out what you're a good fit for in terms of eligibility. I would definitely, there's a lot of excitement around it nationally. And so I know both patients and physicians are excited about it too. So at present time, they're really only used in clinical trial settings earlier than the castrate-resistant space.
Right, but in the United States, there's no legal way to oppose a doctor setting a patient up for Provenge or Keytruda. Is that fair to say?
That's fair to say, but there may not be coverage for it. And Provenge, as well as many other cancer therapies, can be quite costly. And so that's another part of the equation when you're talking to patients about what's right for them. The drug prices off of insurance coverage are quite elevated.
Right, and we're talking in the hundreds of thousands, is that correct? Yeah, so, and we don't know we don't know on large scale how well it, as you said earlier, because these trials haven't been really conducted or we don't know the results yet. Yeah. And
as tempting it is to do more therapies, there are some risks with doing any therapies, and the trials have not yet shown benefit to patients, and so that really does drive our decision making.
Yeah, and do the immunotherapies preclude keep people from getting any other kind of like androgen deprivation, Lupron or Casodex or enzalutamide or any of the others?
Yeah, so typically for most advanced prostate in the castrate-resistant space, patients are typically on continued ADT with either Lupron or Degarelix, or they have castrate levels of testosterone documented. And so in that setting, some practices do combination of an additional therapy while patients are getting Provenge. For the most part, with Keytruda, patients are not on additional therapies because they have most likely advanced through hormonal therapies at that point when they're getting that immunotherapy.
So with Keytruda, as you just said, most people are not getting something else, but with Provenge, they probably are. How do you know if the Provenge is working or whether it's the Provenge or it's the other stuff? So
in the trials from Provenge, an important point, if you're going in to get it, you need to know that it does not really show any benefit in terms of time to progression, and it does not show any massive change in PSA. And so when you get Provenge, you're getting it, but you don't necessarily know if it's working or not. You just need to know that in the trial, it showed that survival benefit. And so you won't watch your PSA and you won't ensure that PSA is dropping, and you won't see necessarily any change on scans.
Yeah. So anxiety really is a side effect for Provenge, at least. And that, I mean, it's worth repeating. There's no way to sort of measure success or failure or progress or whether it's doing anything with the typical PSA test. I mean, you're just hoping, and each day you wake up is perhaps a sign of success. Each day you wake up pain-free is a sign of success. By the way, do any of these affect pain levels, like around metastases or such?
So in some patients that have had really impressive immunotherapy responses with Keytruda and rapid PSA decline, there have been reported improved pain symptoms, and that's specifically in patients with bone metastases. So that can be a benefit to patients if they have a good response.
So anything else aside from the possibility of relief from pain?
If they have
around immunotherapy.
So if you have a substantial PSA response and radiographic response, that can, for individual patients, help with survival.
No. I meant around immunotherapy. I mean, the immunotherapy. Did I misunderstand? Is it possible that Provenge and perhaps Keytruda can help with pain as experienced with patients?
The Provenge, I have not seen a tremendous amount of pain reduction in that setting.
Okay. Is there anything else like, are there any advantage? We talked about side effects. Are there any advantages to using immunotherapy relative to side effects like fatigue or we talk muscle aches perhaps, or something like that? The studies have not really published on terms of a quality of life improvement. The select group that is able to get the immunotherapy really is benefiting from the disease control. Okay. So we've got these two immunotherapy opportunities. They're insanely expensive. So unless, you're in the top percentage of wealth in a developed country, you're probably not going to have the opportunity to pick and choose when you want it. And it's a developed country thing. I mean, developing countries don't really have the opportunity for this. Is that fair to say?
That is probably fair to say, yes.
Yeah. And but Europe, Asia, there are opportunities for Provenge and Keytruda in those places. South America, I imagine, some parts. Okay. So we've got this stuff. Does it help anyone better than anyone else? And I'm thinking about Black men versus white men.
So recently, Dr. Sardor and a fair number of other individuals did publish on a registry of Provenge patients, and that did show that there was a survival benefit for Black patients receiving Provenge compared to Caucasians. And this was a registry study, not a randomized controlled trial. But when you look at it, there was a significant improved overall survival in Black men compared to Caucasians. Now, when you look at the details of that study, it really was most pronounced if the PSA was low, less than 30. And it's also worth noting that Caucasian men had more chemo exposure prior to the Provenge therapy. And so that does have an immunosuppressive effect. Maybe that plays a role in it. So with this data, this is part of the conversation when you're thinking about who should have Provenge. It's not an absolute, guarantee that Black men will have better overall survival. And it's also worth thinking about all the other risks and benefits. But there is some other basic data that has come out that suggests that maybe Black men have, when you look at tumors from Black men versus Caucasian men, that there's a different tumor microenvironment, and that maybe the immune system is interacting in a different way with prostate cancer. But that's not well fleshed out yet, but it's intriguing data.
But it's also kind of cool to have a bit of scientifically based hope too. And when you say Black men, I mean, like in the registry study, how much longer did Black men live than white men?
So the data for all patients that were involved in the registry was 35 months versus 25 months. So
almost a year advantage then.
Yep. And these again, with the Prostate registry is also very low tumor volume, low PSA. Those are the patients that should be considering Provenge.
Okay, so an expensive drug that may be useful, may be more useful for an underserved community than other kind of therapies. I mean, that's sort of interesting, right? It's
interesting. And I do think that the data is not strong enough yet to strongly encourage it. But I think it's, patient by patient, having a discussion about all of the data out there for Provenge and thinking about everything from benefit to cost to preference. And, I think in looking at the racial disparities in prostate cancer, a lot of the VA data has shown that a lot of the disparities is about late access to care and low access to care. And so I think in addition to talking about Provenge, it's really important to talk about tumor testing, making sure that all patients have access to tumor testing. And there has been really important data come out too that shows that when you look at the genetic testing from tumor specimens, there's equal prevalence of actionable mutations in the tumors across all racial groups. So you can't guess who's going to have a mismatch repair mutation. You can't guess who's going to have BRCA mutations. You just need to offer testing to all your patients.
Guys come into your office and they sit down and say, I don't like what I'm hearing. I've got advanced stage prostate cancer. I'm castrate resistant. I didn't like being castrated in the first place. Why can't I just do this immunotherapy all by itself? Forget the ADT, forget everything. We'll just let it run its course. But immunotherapy seems to give me the best chance for quality of life. What's that for you?
So, whenever patients are talking about their preferred treatment approach, quality of life is very important. For the data that we have right now for immunotherapy, patients have been castrated. And so we know that the data that we have is based on that population. And potentially having them with high levels of testosterone, which can drive components of the cancer, could decrease the chance of success of the immunotherapy. And so for the most part, when patients are with an advanced prostate cancer, we talk about risks and benefits of continued castrate levels of testosterone.
Yeah. So in the last few minutes, let's talk about the patient that you see. Like, you've got a guy sitting in your office. Maybe he brought along somebody special to him or not, male or female, child or adult, or hopefully not too much of a child, but somebody who can hear these things. What are you thinking of when you're trying to evaluate whether that you should even mention immunotherapy, you should, but how you sort of encourage or discourage patients from doing immunotherapy?
So when I'm sitting with patients, I talk to them about, we're not able to cure this, but we are trying to get you as long as we can with as good quality of life as we can. And so I do approach all of my patients and offer them tumor testing to see if they could be eligible for immunotherapy with Keytruda or pembrolizumab. And in talking with them, hearing from them about their goals and interests, many patients do opt to have tumor testing done just to see if that is an opportunity for themselves. And then we talk, if they do have an alteration in their genetic makeup, we talk about the risks and benefits of treatment. And part of the risks is, coming into clinic for every 3 weeks infusions. Is that too much of a burden to them, or is that worthwhile to them? So, but I do offer to all my patients the opportunity to look for an actionable mutation.
Right. And, are you ever too old or too young for immunotherapy?
No, because it is really well tolerated in most patients. Age is not really a factor in determining if patients should be getting immunotherapy or not. If people are incredibly frail and we think they have a very short life expectancy, in that setting, we talk about maybe the immunotherapy will not benefit them. And that's because the immunotherapy doesn't directly kill the cancer cells, but it teaches the immune system, so it's a little bit slower onset in its action. So some patients will not have a decline in their PSA for 3 to 4 cycles. That's 9 to 12 weeks. And so if I think a patient is really going to pass away very quickly, that therapy probably won't benefit them.
And is there any way to know when to stop immunotherapy?
So for patients that are responding to checkpoint inhibitors, we have a lot more data from other disease sites where it's used more frequently. And there is some studies looking at, can we, in people with really good response, peel back on the administration of it and see if the memory in the immune system is sustained. So for most patients right now, if they are having a response to Keytruda, we continue it. But I think it will evolve into a place where hopefully we can stop administering it and the immune system has that memory and it's still a persistent benefit.
Yeah. So there's a lot to look forward to in the future around immunotherapy. What we have today is useful. And I mean, you offer it to your patients, so it must be useful. I can only thank you for this conversation. It's given our audience lots to think about, and I'm sure people will have questions for their doctors soon after viewing this. Thank you very much, Dr. Schaffer, and welcome to our conference.
Thank you. It's been my pleasure.